Hello, everyone, and welcome to another intensivecarehotline.com live stream. My name is Patrick Hutzel from intensivecarehotline.com and also from intensivecareathome.com. We'll just give this a couple of more minutes and wait for people to come in, and then we will make a start and get into today's topic. As I said, I'll just let a few more people to come in, and then we will get started with today's topic. Okay, let's dive into today's topic, which is my granddad had a heart attack, kidney failure, and he's in multi-organ failure. What questions do I need to ask to the intensive care team? So this is obviously from a reader, and it's a question we get quite frequently, and let's dive right into it today. So, just give me 1 second, please. Stream at the moment. There we go. I think that's better. Okay, so Granddad had a heart attack, kidney failure, multi-organ failure. What questions do I ask? Very important questions. Very important topic today. And let's dive right into it. So before we go to today's presentation, you may wonder what makes me qualified to talk about today's topic. I am a critical care nurse by background. I have worked in intensive care / critical care for over 20 years in 3 different countries. I have also worked as a nurse unit manager for over 5 years in intensive care. I have been consulting and advocating for families in intensive care as part of Intensive Care Hotline for nearly 10 years. It'll be 10 years in 2023. And I'm also the founder and managing director of Intensive Care at Home, where we provide intensive care at home services for predominantly long-term ventilated patients in intensive care. So that's a little bit about me. Some housekeeping issues. Please type your questions into the chat pad. If you have any, please keep them on today's topic. If you have any questions that are not related to today's topic, please type them in, and I'll get to them at the end of today's presentation. I will also share phone numbers where you can call in live on the show if you have any questions on today's topic. Okay, so let's dive right into today's topic. Granddad had a heart attack, kidney failure, multi-organ failure. What questions do I need to ask? Now, I'm constantly surprised that when families in intensive care come to us with, those type of scenarios, that they really have no clue where to start. And, that is not anyone's fault. It's just a result of intensive care being a highly specialized area, intensive care being very complex. And of course, you wouldn't know where to start. It's like me wondering, well, how do I get to the moon? Well, I wouldn't know where to start, really. Build a rocket ship and get to the moon. It's not as simple as that. I wouldn't really have a clue where to start. And it's the same with intensive care. Where do you start with any complex issue, any complex situation? So you heard me say it before, and I might sound like a broken record, but I also believe it describes the situation best when I say that families in intensive care don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And that's exactly what this question from Pamela illustrates. That Granddad had a heart attack, kidney failure, multi-organ failure. What questions do I need to ask? And you'll get all of that now. Okay, let's start when someone presents with a heart attack into, they're going through ED, emergency department or emergency room. They get an initial assessment there. Maybe the heart attack is diagnosed often by, signs and symptoms such as chest pain, shortness of breath, back pain. Sometimes, as people are very sweaty, cold sweat in particular. Those are the first signs, and then that's often confirmed by a 12-lead ECG, where ECG changes are prominent with ST elevation or sometimes ST depression. Now, I'm not going into ECG reading today here, but that's often what happens. Then next, chest X-rays need to happen. Next, pathology needs to be done. Blood results need to be taken. And one very important blood result you're looking for is troponin. Troponin is the marker in the blood that confirms a chest X-ray. I do believe troponin higher than 0.07 confirms a heart attack. Don't quote me on that, but I think it's about that level. Bear in mind, if someone had cardiac surgery, open heart surgery, their troponin is also high because of the surgical impact on the heart. But again, I'm not going into that. Now, next step, if someone had a heart attack and is going into ICU, is to potentially send them for an angiogram. Now, what's happening in the angiogram? Angiogram is done in a catheter lab. And in the catheter lab, the catheter lab team, which obviously comprises and is often being led by a cardiologist and by nurses as well, technicians. A catheter is inserted through the groin, through the femoral artery, and is going all the way up to the heart to diagnose where blockages are, where coronary arteries are blocked. Because that's basically what happens during a heart attack. Coronary arteries are blocked for whatever reason, lack of oxygen to the heart, and the heart muscle gets damaged often. And therefore, the heart needs to be unblocked as quickly as possible. And that can be done with a dilatation, can be done with an angioplasty, also known as a cardiac stent. Right? Those are the options. Now, if a stent can't be placed for whatever reason, because the risk is too high for the artery to rupture, then often next steps could be cardiac surgery, i.e. coronary artery bypass grafts, so that the blocked arteries can be circumvented with new grafts attached to the heart, so that the heart muscle can be reperfused with oxygenated blood and can continue to function. So those are some options. So, you get a cardiologist, do an angiogram. If stent or dilatation can't be performed, let's make a referral to a cardiac surgeon and see whether open heart surgery should be performed. Other treatment options are fibrinolytics, also known as medications. There is urokinase, streptokinase, tissue plasminogen activator, aspirin, also known as thrombolysis, to again break down the clots in the coronary arteries and re-establish perfusion to the heart. So those are options, first line treatment options. And those need to happen very, very quickly. We're talking about minutes and hours, ideally. In theory, if the heart has no oxygen perfusion for more than 3 minutes, the heart tissue, heart muscles is damaged irreversibly, which obviously could lead to a loss of function of the heart, loss of contractility, ejection fraction will drop down. But I'll talk about ejection fraction separately. And then, it needs to be reassessed whether the heart can function or not. Now, imagine the heart muscle is damaged irreversibly. Again, that leads to an irreversible function of the heart muscle. That increases the risk for arrhythmias such as atrial fibrillation, heart blocks, VF, VT, that could lead to cardiac arrest. So the risk to sustain a cardiac arrest after a heart attack is very high, or it's much higher, So those are questions that need to be asked. Next, often after the thrombolysis, a heparin infusion is started as well. If your loved one has a cardiac stent or a PTCA, they're often started on Plavix as well, which is a specific antiplatelet drug that if you have a stent, which is a metal stent, often if you're not taking an antithrombolytic drug, the stent could block as well, because it could attract platelets, right? And then the stent blocks, and then you're back to square one. So other options after the heart attack could be a balloon pump. So what happens is, if, again, cardiac output is very poor, right? A balloon pump might be the next step. A balloon pump helps to reperfuse the coronary arteries as well. It's an invasive device. Basically, a balloon is placed in front of the coronary arteries, and again, it's helping to re-establish cardiac perfusion, re-establish perfusion with arterial blood to the coronary arteries. So I'm not going into detail today how a balloon pump operates, but it is important for you to know that such a device is there. And again, this is usually a device that is being inserted in the catheter lab in most cases. Some balloon pumps are inserted in the operating room or operating theater, but in most hospitals/ICUs, it is actually being inserted in the catheter lab with the cardiologist and the cardiology team there. Next, if, God forbid, a balloon pump, vasodilators, vasopressors, inotropes are not effective, another option might be ECMO. Now, in this situation, Pamela says her granddad had a heart attack, and for ECMO, I do need to put in a disclaimer here in terms of that in most countries, most ICUs, there's an ECMO cutoff at the age of 65. Now, Pamela, you haven't shared the age of your granddad. Maybe he's 60, maybe he's 65, maybe he's 75, maybe he's 85, maybe he's 95. We don't know. But the cutoff, generally speaking, for ECMO is the age of 65. And that's only if, contractility is poor, multiple inotropes have been started, ejection fraction is very poor. And again, we'll talk about ejection fraction in a minute. Funnily enough, after a heart attack, I've seen both scenarios. I have seen scenarios where someone is hypertensive, meaning they have a high blood pressure, and therefore they need to be started on GTN, get GTN spray, get a GTN infusion started, or get a sodium nitroprusside infusion started, also known as SNP, to get the blood pressure down. They are vasodilators. On the other hand, if ejection fraction, for example, is really poor, then often patients crash and have a low blood pressure. And then other medications such as inotropes or vasopressors need to be started, such as noradrenaline, norepinephrine, levophed, adrenaline, epinephrine, vasopressin, but also cardiac specific drugs that can increase contractility and pump function. And those drugs are, generally speaking, dobutamine, milrinone, sometimes dopamine. And sort of in the last 10 to 15 years in some ICUs, they've also used levosimendan, right? So they increase pump function of the heart. Now, on the other hand, if someone is on GTN spray, GTN infusion, SNP infusion, their resistance in the vessels drops down. Their systemic vascular resistance drops down, and then their blood pressure might crash as well. And then you're chasing a low blood pressure on the other end. So it's a bit technically what I'm talking about, but there are many variables in this that need to be managed, and that's why people are in ICU, why patients after heart attack are often in ICU, because people can crash very quickly. People can go from low blood pressure to high blood pressure and vice versa, and you need to monitor them closely. They also, most of the time, need to have an arterial line inserted. They need to have a central line inserted so that, inotropes or vasodilators can be given, that sedation can be given when needed, and so forth. Now, next, I talked about ejection fraction. What does that even mean? So ejection fraction hones in on the contractility or the pump function of the heart. Now, how can you determine an ejection fraction pretty quickly after a heart attack? The first step would be to do an echocardiogram or an ultrasound, just through the ribs. If visibility is poor there for whatever reason, you can do a transesophageal echocardiogram of the heart, but that means you have to insert a camera through the esophagus, which is very invasive, and often patients have to be induced into a coma. They have to be intubated, so you should not necessarily go for a transesophageal echocardiogram or ultrasound unless you can't avoid it, of course. It is important to find out an ejection fraction after a heart attack. If ejection fraction is 40% or less, pump function or contractility of the heart is impaired. Again, going back to what I said before, do inotropes or vasopressors need to be started? Do drugs like Lasix or furosemide be given, diuretics, to offload the heart because pump function is poor? Do patients need to be put on a fluid restriction so the heart is not getting fluid overloaded? Those are all questions that need to be asked. Other issues that can happen, if ejection fraction is poor after a heart attack, again, I mentioned it briefly before, are there arrhythmias? A lot of patients after a heart attack go into what's known as atrial fibrillation, AF or AFib, right? Which means the heart is beating in an irregular rhythm, which then increases again the risk of potentially another heart attack, because it's easier for a thrombus to be developed if there's AF or atrial fibrillation. That's why anticoagulation, either with, initially with urokinase, streptokinase, aspirin, potentially heparin infusion, is so important in those situations. Okay, next. Coming to other drugs that can be given sometimes if ejection fraction is poor is digoxin, because again, it increases the contractility of the heart. If there is AF, atrial fibrillation, medications that can be given is amiodarone, also digoxin. Electrolytes need to be checked. Potassium and magnesium need to be checked. If they are low, do they need to be replaced? Probably. You don't want a potassium or a magnesium that's out of range. Potassium is usually should be between 3.5 to 4.5 millimoles, and magnesium should be above 0.9 to 1.0 millimoles. So again, those those electrolytes need to be kept a very close eye on, and they need to be replaced, those electrolytes, if they're out of range. Now, sometimes the potassium or magnesium can also be very high, especially, Pamela, with your granddad being in kidney failure, his potassium might also be high. Again, you haven't shared that because you probably didn't know what to look for, what to ask. When patients go into kidney failure, sometimes potassium can be high as well. And that can sometimes be treated with Lasix or furosemide, also known as diuretics. Or they can be patients can go on a dialysis machine, which is what's probably going to happen with your granddad at some point, and have the electrolytes managed that way. When someone is on dialysis, usually electrolytes are being removed, and then you got to monitor those electrolytes again very, very closely. So next, it is not unusual that when someone gets into ICU after a heart attack, that they're very anxious. No surprises there. You can manage the anxiety and pain with medications such as morphine. You can manage the anxiety and pain also with benzodiazepines such as diazepam, to help manage the anxiety without, quote unquote, knocking out people completely. Next, I talked about that patients probably need an arterial line. They need a central line. It's very good with an arterial line to do arterial blood gases. I'll talk about that in a minute. It's very good and very important to have blood pressure measured continuously when someone had a heart attack, because, as I mentioned in the beginning, some patients go from hyper to hypotension very, very quickly. Next, let's talk about ventilation. Do all patients need to be ventilated in ICU after a heart attack? Not necessarily. There are patients that you can treat with oxygen. They need close monitoring. They need to be sitting up, and they don't necessarily need to be ventilated, which is the ideal scenario. But there are some patients that need to be put on BiPAP or on CPAP straight away, because sometimes they're struggling to breathe, and then you need to counterbalance that straight away, with maybe oxygen therapy to begin with, nasal cannulas, high flow nasal bronchs is the next step, maybe then BiPAP or CPAP to help them breathe. If, God forbid, that all fails, patients need to be intubated, but that should be a last resort. The goal should be to keep a patient off the ventilator and intubation as much as you can. If they need a little bit of BiPAP, CPAP, and which is non-invasive ventilation, that is the preferred option, assuming they're not at risk of aspiration. Okay, next, what else can happen? What else can happen during heart attack in ICU? Sometimes you want to measure how effective treatment is, i.e., you want to measure what your cardiac output and cardiac index is, especially if you're on multiple inotropes or vasodilators. You want to find out, how's your heart doing? What's your cardiac output, cardiac index? And then, you could insert what's known as a PA catheter, also known as a Swan-Ganz catheter, and you can do invasive management from the pulmonary artery. And you can also, another alternative is a pico catheter, where you can get those measurements. What you can also do is you can get a mixed venous blood gas from a PA or Swan-Ganz catheter. Again, that'll give you a very good indication on organ perfusion, on cardiac perfusion, and so forth. You can check your SVR, your systemic vascular resistance. Again, that gives you an idea of whether someone is shutting down peripherally, how you need to titrate inotropes. Do you need to go up? Do you need to go down? You also need to look at things such as urine output. Is your therapy working? Are the kidneys perfused? Because if your blood pressure is too low, right, your kidneys are not going to be perfused, and then they might shut down as well. And if the kidneys are shutting down, that's when you start doing things such as you're giving diuretics such as furosemide, Lasix, and then as a next step, you might be starting CRRT or dialysis, So this is also the reason why your granddad might have gone into kidney failure, probably because his blood pressure was too low, which probably suggests that his contractility has deteriorated, and he that's why the kidneys probably have shut down. Okay, what else? So patients obviously need to be very, very closely monitored in ICU. They are at risk of getting an infection, especially if you start ventilating them invasively with a breathing tube. Then you've got all these issues around VAP, ventilator associated pneumonia, and that's a big challenge in and of itself. Then you might add on complications by starting to ventilate a patient. Then you also have to sedate them. Have to put them in an induced coma. You have to start medications such as propofol or midazolam, also known as Versed, or you start them on Precedex. Then you often have the added on complexity of patients becoming hypotensive. They might already be hypotensive. That's why it's so important to try and keep patients off the ventilator as much as you can to avoid any unnecessary complications. But that's not always possible, depending on a number of factors, including age of a patient, including comorbidities of a patient's pre-medical history and so forth. But it would be important to try and keep patients off the ventilator as much as possible. So then you are saying also, Pamela, that your granddad is in multi-organ failure. Well, one could argue he is. If his heart has failed with a heart attack, if he is in if he's in kidney failure, then there's 2 organs failing. Now, you haven't commented on whether your granddad is ventilated or not, but if your dad is ventilated, it's more or less triple organ failure, which is multi-organ failure. One could argue that even the heart and the kidney failing is multi-organ failure. It's 2 organ failures. Yeah, you could argue that's multi-organ failure as well. But, one way or another, it should not discourage you to, ask all the right questions, and, keep pushing along to get the best outcome for your grandfather. Okay, other treatment options that often come into play in situations like that are beta blockers. Beta blockers, for example, are there to get the blood pressure down as well, but that's can be done IV intravenously. But ideally, again, you don't need to intubate the patient to begin with, and you can give beta blockers such as metoprolol orally, or through a nasogastric tube. That's the other question. Should your granddad have a nasogastric tube? And it really depends. Again, it depends on whether he can eat and drink. If he's intubated, he needs a nasogastric tube to, manage his nutrition. Okay. Also, it's not uncommon that after a heart attack, a lot of patients in ICU feel nauseated, and they're at risk of vomiting. You might, and that's why a nasogastric tube might help just to manage the reflux, and that might also decrease the aspiration risk. And if your loved one is ventilated, if your grandfather is ventilated, you can then also give him nutrition. They can give him nutrition that way. Okay, so also, if your grandfather was unconscious for a period of time, they also have to think about, has there been low oxygen supply to the brain if he was unconscious for a period of time. So the question here is, do they potentially need to do a CT scan of the brain, an MRI scan of the brain, EEG of the brain? Is your granddad confused? If he's not ventilated, if he's awake, is he potentially confused? If he's confused, it could just be from the event, but has a neurological event taken place, right? So those are all questions that need to be asked in a situation like that. Okay, now let's just open up the floor for questions if there are any. I'll just quickly type also the numbers in the chat pad if you want to dial into the show. For our US audience, the number is 415-915-0090. For our Australian audience, the number is 041 094 2230. That is for our Australian audience. And for our UK audience, you can dial 0118 324 3018 is for our UK audience. And I would welcome your questions and phone calls now. So you can you can ask questions live on the show. Okay. So that pretty much concludes today's topic. What questions to ask if you have a family member, and in your situation, family, your granddad in ICU with a heart attack. But that pretty much concludes what you should be asking one way or another. So if there are no questions, that's great. You can also comment below when you watch the uploaded recording here what questions you have, and I will answer them on YouTube. Or if you comment what you want to see as a next topic, as another topic. As you can see, those topics are all driven by subscribers or readers or clients' questions. So you can type your question here, and then I can make another video about it, whether that's a live stream or a quick YouTube video. I will answer those questions in one format or another. Now, before we close this off, so let me quickly tell you that if you have a loved one in intensive care and you need help, please go and check out intensivecarehotline.com and call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com. Also, have a look at our membership for families in intensive care at intensivecaresupport.org. There you have access to me and my team 24 hours a day, and we answer all questions intensive care related. Also, if you need a medical record review for your loved one in intensive care, or even after intensive care, especially if you suspect medical negligence, you can contact us as well. We can help you with that. We can interpret medical records, in real time, and help you, piecing the puzzle together, help you ask the right questions. We can also look at medical records and then talk to the doctors directly and ask all the right questions. So there's a number of things we can do. And if you like this video, give it a thumbs up, give it a like, and subscribe to my YouTube channel for regular updates for families in intensive care. And share the video with your friends and families. And comment below what you want to see next. Click the notification bell. Thank you so much for watching today. And I'll see you during the week with more quick tip videos. And I will do another YouTube live stream next Sunday, 10:30 or 11:30 a.m. Australia time, Sydney, Melbourne time, or 7:30 p.m. Eastern Standard Time in the US, which is 4:30 p.m. on a Saturday. All times in the US are on a Saturday, 4:30 p.m. Pacific time next Saturday. Thank you so much for watching, and have a good weekend and a good week, and I'll talk to you next time. Thank you.